Okay, let's dive into this. To truly master the SENDIS classification, you absolutely have to start with a rock-solid understanding of the anatomy and the underlying pathology. You see, Mirizzi syndrome isn't just your run-of-the-mill gallstone issue. It specifically occurs when you have a gallstone that becomes fiercely impacted right in the cystic duct, or in that little outpouching we call Hartmann's pouch. And from that specific, tightly packed position, the stone does something dangerous. It pushes outward, causing external compression or even physical erosion of the adjacent common hepatic duct. This precise anatomical definition right here, that is the foundational key to unlocking literally everything we're about to cover today.
So, here's our quick roadmap. We'll hit the Mirizzi syndrome classification, dive into surgical management strategies, share a high-yield clinical pearl, uncover the classic exam trap, and finish up with a quick recall test to lock it all in.
All right, Section 1, Mirizzi syndrome classification.
Let's move to and see how this builds, because it's not just a list, it's a chronological story of a worsening disease. The pathology of Mirizzi syndrome is this devastating progressive cascade. It starts simply enough with just physical pressure, right? Step 1, compression. But as that stone just sits there, relentlessly pressing and causing severe inflammation, it starts to wear away the actual tissue. And that leads to step 2, a small fistula, an abnormal connection. Left untreated, well, that hole grows into step 3, a larger fistula. Eventually, the relentless erosion causes step 4, which is complete bile duct wall destruction. And then, in the most extreme chronic cases, the inflammation actually involves the nearby bowel, leading to step 5, an enteric fistula. Visualizing this worsening timeline makes the classification system we're about to see so much easier to grasp.
And here it is, your ultimate screenshotable master table, the SENDIS classification. Let's firmly anchor these cutoffs in your memory right now. Type 1 is just external compression of the common hepatic duct. There is absolutely zero fistula yet. Type 2 is where the erosion finally breaks through, creating a cholecystabiliary fistula, but, and this is key, it involves less than 1/3 of the bile duct circumference. Type 3 means that fistula has grown, now involving up to 2/3 of the circumference. Type 4 is total devastation, complete destruction of the bile duct wall. And finally, type V steps outside the biliary tree completely. It's a cholecystoenteric fistula, meaning a connection to the bowel, because, apparently the gallbladder decided it was tired of the biliary tree and wanted to make some new friends in the GI tract. Also, notice type V is split. VA comes with gallstone ileus, while VB is without gallstone ileus.
Moving right along to Section 2, surgical management strategies.
For the early stages, so types 1 and 2, our overarching golden rule in the OR is simple but incredibly critical. Avoid iatrogenic bile duct injury. The anatomy here is massively inflamed, distorted, and frankly, quite dangerous. You're going to perform a cholecystectomy, but if the anatomy is just too hostile, a subtotal cholecystectomy is a much safer bailout option. You have got to avoid aggressive dissection in the porta hepatis. If there's significant obstruction, you might need to establish biliary drainage. And for type 2, where you have that small fistula of less than 1/3 the circumference, you'll need to carefully repair or drain that specific defect. But man, when we hit types 3 and 4, the surgical complexity literally skyrockets. Remember, we are now dealing with massive fistulas up to 2/3 of the circumference, or just complete bile duct wall destruction. A simple repair? Yeah, that's no longer an option. These patients require extensive, complex biliary reconstruction. Biliary drainage is highly important here. In fact, in many of these type 4 cases, the destruction is so profound that a Roux-en-Y hepatojejunostomy is entirely necessary just to reestablish biliary flow. Because of this massive escalation in technical difficulty, management at this stage absolutely demands the skills of an experienced hepatobiliary surgeon.
Then we have type V, those cholecystoenteric fistulas, and surgical priorities here completely diverge. For type VA, the patient has a gallstone ileus. That means a massive stone has actually traveled through the fistula and obstructed their bowel. This is a life-threatening emergency, so your immediate priority is to treat the intestinal obstruction first. Only after that is resolved do you go back and manage the biliary anatomy, depending, of course, on how stable the patient is. On the flip side, type VB has no bowel obstruction, so your primary focus shifts immediately to addressing the fistula itself and the underlying biliary disease.
All right, Section 3, a high-yield clinical pearl. So, the crucial point is this overarching simplification. If you want to remember this easily, you can chunk the entire SENDIS classification into 3 easy buckets: Bucket 1, type I simply equals compression. Bucket 2, types 2 through 4 equal a progressive cholecystobiliary fistula. It's just getting wider and wider until the duct is destroyed. And bucket 3, type V, equals an enteric fistula involving the bowel. If you memorize those 3 basic buckets, you can pretty much deduce the rest of the details on the fly.
And to make sure you never confuse those type V modifiers on a test, use this really simple trick. Type V is with gallstone ileus. Type VB is without gallstone ileus. Just remember, A means the ileus is actively happening, and B means it's been bypassed. Lock that memory hook in, and you are golden for the exams.
Section 4. The classic exam trap. Watch out for this one. Mirizzi syndrome is not a common CBD stone. Actually, scratch that. Let me say it with a bit more emphasis. Mirizzi syndrome is not a common bile duct stone. This is hands down the single biggest novice misconception out there. Now, what's really interesting about this is how test writers actively try to trap you. Trap number 1, they'll try to trick you into thinking the stone is inside the common bile duct. It is absolutely not. The defining feature is that the stone is lodged in the cystic duct or Hartmann's pouch, causing external compression of the common hepatic duct from the outside. Trap number 2 revolves around the fistulas. They love to give you a clinical vignette describing type 1 and try to make you blindly select an answer involving a fistula. Remember, type 1 has compression, but absolutely no cholecystobiliary fistula. Don't let them trick you.
Finally, Section 5. Quick recall test. Let's see what you've retained.
All right, here's your scenario. An impacted stone in Hartmann's pouch compresses the common hepatic duct, but there is no cholecystobiliary fistula. I'll give you a couple of beats to formulate your answer. So, what is the season's classification for this exact patient?
And this brilliantly illustrates our foundational concept. The answer is Mirizzi type 1. Because there's external compression, but the tissue hasn't actually eroded into a fistula yet, it's strictly type 1. And remember, your primary goal above all else in this hostile anatomy is to avoid iatrogenic bile duct injury. But it really begs the question, doesn't it? If this much destruction can happen just from external pressure, what other hidden anatomical traps are waiting to surprise you in the biliary tree? Thanks for joining me on this explainer, and keep up the fantastic work.